speak here. It's an incredible honor. I'm gonna do my best to stay within my timeline and speak at a rate that the translator can use, but I suspect I will fail at both. So, pulmonary hypertension is a terrible disease. Everybody hates it. It has high morbidity, high mortality rates, but the problem is that with younger and younger kids being born 23, 24 weeks of gestation, we have more pulmonary hypertension. With more kids with congenital heart disease that we are treating, we are going to have more pulmonary hypertension. So it is critical that we understand what we're doing for these kids. And what I want you to take from this and my second talk, which is basically the same kind of grouping, is that it is critical in the beginning that we understand what type of pulmonary hypertension they have, because one size does not fit all, okay? So I'm going to talk a little bit about what normal pulmonary vascular physiology is so that we can then talk about what pulmonary hypertension is. We'll talk about a little more time about the evaluation process, again, to focus on knowing what you are treating so that you have the right stuff. Not all pulmonary hypertension should be treated with medicines, okay? That's a critical thing. And then we will talk about what our options are for treating both medically and surgically. So, to start, I want to remind us about how the pulmonary vascular bed works. So these are three different ways of looking at the same thing. This is my drawing of an alveolus interacting with the capillary. We have the arterial coming in here that's taking the desaturated blood from the veins and from the right side of the heart. And this is where your arterioles are, your vascular smooth muscle, as we see down here and here. And this is where 95% of the pulmonary vascular resistance in the lungs exists. Sorry about that. So we know then that the blood comes in here, we have gas exchange, carbon dioxide out, oxygen in, and then that saturated blood flow will return back to the left atrium and get pumped out to the body to move on, right? Now we know that the endothelial cells are interacting with the blood flow in the blood vessel lumen. And they really are the brains of the pulmonary vascular bed. As you have increased flow, as in exercise, those endothelial cells will then interact with the vascular smooth muscle and tell them to dilate, to let the blood in without increasing the blood pressure. Now they do that through three different mechanisms. There is the nitric oxide pathway, the endothelin-1 pathway, and the prostacyclin pathway. And their default, when the endothelial cells are working properly, the default is for those vessels to stay dilated to make this lumen size as big as possible so that you have a bigger total vascular lumen size across the entire pulmonary vascular bed, because that's what the right side of the heart is reacting to. And the right side of the heart is a very low pressure, low work type of chamber. So again, the bottom line is endothelial cells are the brains of the pulmonary vascular bed. This is the muscle of the pulmonary vascular bed, and they respond to what they are seeing. The other thing to remember is that as flow comes in, they respond in the lumen. Also, as high oxygen levels come in, as low carbon dioxide levels come in, it tells the endothelial cells to say, dilate here, I can do gas exchange, send a lot of blood here. When it's low oxygen or high carbon dioxide, it shouldn't go there, and we'll talk about that more in a second. So, as you recall, for those of you who are closer to medical school than others, or whether you weren't or not, it's something that still affects all of us. We remember the west zones of the lungs, and in essence what they tell you is that at the very tops, or the apices of your lungs, if you're standing up, or if you're laying down, the very anterior part of your chest is what's considered the zone 1. And that's where the alveolar pressures are highest, such that they compress the blood vessels so that no blood is actually coming into those top zones. And so you have no gas exchange. You're ventilating, but you don't have blood coming in, so you don't have oxygen coming in or oxygen coming out. Thankfully, in healthy lungs, that's a small part of the bed. More importantly is as you go down with gravity, you have more zone 2 and zone 3, where the majority of your gas exchange, which is where all of your gas exchange is occurring. And so, in healthy lungs, this is 80–90% of your lung bed. Now, the other part to remember is that, as I said before, is that this is the blood vessel, the collective lumen size in the top part of the zone 1. It's a little less tight in zone 2, and it's wide open in zone 3. That collective, if you take all of those blood vessels together, that collective cross-sectional area is the pulmonary vascular resistance that the right side of the heart is working against, right? Now, when you increase cardiac output, when you're exercising, when you're sending more blood into your lungs, the blood vessels respond by having the endothelial cells tell the vascular smooth muscle to dilate. Make these blood vessels bigger. Make it easier for blood to get into the lungs. And if you see here, if you remember from my last picture, this zone 1 is smaller, zone 2 is a little bigger, and zone 3 is a lot bigger, so that the pulmonary vascular resistance in exercise falls in a healthy person. It falls, it gets lower. And that's because as you have increased flow going into the lungs, the endothelial cells should respond appropriately. And that's great. And so in a normal person, in the typical person, in a healthy state, your pulmonary vascular resistance will fall such that the blood pressures in the lungs actually don't increase with exercise, unlike in the body where they will increase significantly. Now, the reason for even having the ability to have constriction in the lungs, because otherwise you'd think it's just pathologic, it's not helpful. Well, in certain scenarios, it's critical that this happen. Let's say that your whole right lung is full of pus from a pneumonia. You don't want blood going in there. If I send blood into a lung segment that is full of pus, and I have it go through, it'll come out just as desaturated and just as hypercarbic as it went in, and you'll now have oxygen saturations in the 70s or 80s. Instead, what it says is, don't send blood here. I can't do anything with it. I'm really sick. And so instead, it's just like exercising, but just to one lung. So it drops all the blood vessel pressure in the other side. It sends all the blood to the other lung. And in healthy lungs, you can do that enough that the pressures, the pulmonary artery pressures, don't increase very much at all. Maybe a little bit, but not enough that it actually affects the heart. The right side of the heart says, all right, this is a little more work, but it's not that big a deal. I can take it. And then over time, as you treat this pneumonia and it starts to get better, that zone 1 slowly starts turning into zone 2, and then it starts turning into zone 3, and the distribution of the blood flow to the lungs normalizes, and you go back to a healthy state. So that's why there's vascular tone in the lungs at all. The problem is pulmonary hypertension is a pathologic increase in pulmonary vascular resistance. We talk about high blood pressure of the body. It's all over the place. I've had it since I was a kid. I'm still here to bother you, right? But the problem with pulmonary hypertension is it occurs to a chamber, a right ventricle, that is not designed to handle high pressure. The right ventricle is a very wimpy chamber that is designed to handle about 20% as much pressure as the left. And so in a biventricular circulation, pulmonary hypertension results in progressive strain and failure of your right ventricle. If you're a single ventricle, which I don't want to spend more time on now, but if you're a single ventricle where you don't have a pumping chamber sending blood into the lungs, the body says, I don't know what to do with this, so it tries to make extra blood vessels to deal with it, which themselves turn out to be pathologic. Now, the true definition of pulmonary hypertension is that you have a pulmonary vascular resistance greater than 3 Woods units meter squared. And if you have normal cardiac output, you will also have a mean PA pressure of greater than 25. The data now would tell you that abnormal is above 20, but most people don't treat that low. So that is the definition of what we call pulmonary arterial hypertension. I say that specifically because you'll see there's differences here that we need to understand. Now, here's why people hate this disease, and rightfully so. Untreated, 3 to 4 year median survival. So 50% of people are dying within 3 to 4 years of diagnosis of this disease. It's terrible. And even over my career, over the last 15 plus years, the amount of medicines we have increased significantly. But even in that setting, still 10-year survival rates are only 50 to 70%. It's still a very bad disease. But the difference is that, one of the things that I talk to my fellows about all the time is you don't treat all pulmonary hypertension the same. When you know they have it, now's when you do a lot of the work to figure out why they have it. So just one more graphic to kind of differentiate between the types of pulmonary hypertension before I show you a couple cases. Now, and what I want to clarify again is I'm talking about group 1 for this talk only, and that's this precapillary pulmonary hypertension. This is a disease almost invariably of the endothelial cells in the pulmonary vascular bed. And we see this in the genetic, familial types, or idiopathic, we don't know. Congenital heart disease is the other one we see a lot. When you have high pressure heads going into the lungs, they respond by increasing their tone. And persistent pulmonary hypertension in the newborn. So this is, again, is a mean pulmonary artery pressure greater than 25, a mean pulmonary vascular resistance greater than 3. But the other part I didn't say before is that you have a wedge pressure, so a pressure on this side, less than 15. come back to that in a second. Now, this is not even less, this is a little less than half of all pediatric pulmonary hypertension. And of that, about 2/3 is from congenital heart disease, and about 1/3 are idiopathic or genetic. Now, post-capillary, people tend to lump these together, but post-capillary pulmonary hypertension, or group 2, everything's the same as the diagnosis, except in this setting, you have a wedge pressure of 15 or more. And that means that you have a backup of pressure, the concept being that it's like a clogged sink and everything is backing up. And if you make your alveolus full of water because you have pulmonary edema from left heart failure, whether it's from preserved or reduced heart ejection fraction, or you have pulmonary vein disease or mitral valve disease, that chronic retention of fluid here that causes chronic pulmonary edema, causes chronic hypoxemia, chronic hypercarbia, and over time that causes chronic increase in vascular tone. And left untreated, you can develop irreversible pulmonary hypertension. And then group 3, which turns out to be the fastest growing group in our world, is the capillary type of pulmonary hypertension. In our world, that's chronic lung disease, interstitial lung disease, et cetera. That's almost half, and that's, you know, it's an amazingly growing, and a lot of this is because of the success of our colleagues in neonatology being able to resuscitate babies at 22, 23-week gestation. Now, you know, as I said, this talk is purely about group 1 pulmonary hypertension, and that's the idiopathics and the genetics that we know about, the congenital heart disease 1.4.4. The other thing, though, that people kind of forget about is that pulmonary veno-occlusive disease is an unusual one to have in group 1. Now, again, veno-occlusive disease means that it's a problem with the venules. It's on the other side of the capillary. It's a place where muscular tone, vascular tone should not exist. But in patients who have this, they progressively develop narrowing of that pulmonary venule bed that results in a very similar concept and physiology to group 2 pulmonary hypertension. But it's in the group 1 because until they don't, they respond very much like group 1 patients. And I'll show you an example in a little bit. Last, that they've also added this, they've added a lot of attention in the groupings to the persistent pulmonary hypertension of the newborn. We see this in Down syndrome, meconium aspiration, respiratory distress, these kind of things. These are almost all reversible. The Down syndrome is not, of course, but the other ones are reversible causes of pulmonary hypertension that you can treat and get them through. So first case, I've got 2 8-year-olds I'm going to present to you with very different outcomes. First one's an 8-year-old, had passed out several times, went to an ER, had a chest x-ray that suggested his heart was big. They got a CT scan out of concern that he might be having pulmonary emboli. He did not, but his pulmonary artery was big. And Dad, who wasn't the world's best historian, but knows his boy well, he says he's otherwise a pretty active guy, except for those 2 passings out. And he had normal vital signs. Well, his EKG, doesn't show up great, but the EKG here demonstrates, you know, he's 8, so he has a right QRS axis deviation based on the fact that his QRS complex is predominantly inverted. And he also has pure R waves in V1 through 3 consistent with the right ventricular hypertrophy pattern. Now, T-wave inversion in an 8-year-old in the early precordial leads is normal, so that is not a strain pattern. So you read this as right ventricular hypertrophy with right QRS axis deviation without a strain pattern. That's concerning. Next, we get his echocardiogram, and his 4-chamber, his RV looks pretty good. You know, in retrospect, we say, yeah, maybe it's thick, I don't know, but when you know, all my exams are better when I know what the echo looks like. But it's squeezing great. You look at his short axis, his septum isn't particularly flat, but when you get his tricuspid regurgitation jets, it's close to 60 millimeters of mercury. This guy has pulmonary hypertension, no question about it. Let's talk about the next guy. Another guy, 8-year-old, active guy. He saw my pulmonology colleagues because he was tachypnic, and he was a little desaturated. He was breathing fast all the time, but otherwise pretty healthy guy. He had a normal lung function test, normal diffusion scan. But his SATs when we saw him were in the low 90s. He didn't have clubbing, but his SATs were in the low 90s. That's not normal, and he was tachypnic. There was no question about it. Exact same EKG, except this guy, 8 years old as well, has T-wave, upright T-waves in V2 and V3. That's a strain pattern when you have right QRS axis deviation and right ventricular hypertrophy. Basically the same kind of story, except desaturated. Echo, 4-chamber, looks pretty normal again. His septum's more flat though. You know, again, you read these when you have light of what you think's going on, but he definitely has some more flattening of his septum, which goes along with a tricuspid regurgitation jet of 100. So 2 guys, pulmonary hypertension, 8 years old, came in not long after one another. The thing is, the devil's in the details on how we evaluate them, right? So we have 2 kids that I'm certain, they've got pulmonary hypertension. But what else should I be doing? So the next thing I'm going to do is try to get a better sense of, as Dr. Ayers was talking about, symptoms are very relative. If you don't do anything, it's hard to be symptomatic. I maintain asymptomatic state all the time by doing this, right? So this oftentimes is useless. It's oftentimes useless. So exercising them. Problem is, an 8-year-old's not going to do a treadmill. They just won't. 6-minute walk test is the easiest, and it's a very nice, reproducible, simple thing you can do. Just how far can you walk in 6 minutes? There are standards for your height and age, and you know, we can get a good sense of where they are. Their BNP gives us a sense of how their right heart is tolerating, or you don't know which side, but in this setting, it's the right heart, how well they're tolerating life. And then you got to start looking for other causes. We go in assuming everything is group 1, idiopathic or familial, but you just don't know. And if you assume, you know what happens, right? Well, in the U.S., it's not good. So we do 2 big sets of things. We look at labs first. We're looking for other etiologies. Do they have liver failure? Do they have HIV? Do they have a genetic etiology? Do they have rheumatologic autoimmune problems? Do they have a clotting problem? We're also going to look for a lot of lung potential pathology, get a chest CT, x-rays, look at their liver scan, look at their lung function to get a better sense if there's a lung disease. But cath, I know where I am right now, and I recognize that this is one of the most important things that we're going to do for these patients, and obviously it's something that you guys do here every day. So cardiac catheterization, it's the gold standard assessment of pulmonary artery pressures. We know that echocardiograms over and underestimate right heart pressures all the time. So we got to verify the diagnosis in the cath lab, and then we're going to calculate our pulmonary vascular resistance, which you can't do any other way. We're going to assess for any signs of the 1.4.4, the congenital heart disease. We're looking for any shunting going on, looking for other types of pulmonary hypertension. We're going to get a wedge pressure. We need that to calculate our PVR, but we also need to look and see whether our pulmonary capillary wedge pressure is greater than 15. Is this a left heart obstructive problem? I'm not advancing. Oh, okay, here we are. So group 3, we want to get what our alveolar arteriolar gradient is to get a better sense of whether our lungs are abnormal. And then the last part, and the super important part in the cath lab, is getting a sense of what our right ventricular function is. You're going to see time and time again that function is the key. Knowing what our function is, both outwardly and of the right ventricle specifically, is critical to taking care of these patients and knowing when to advance. So I want to know what my RV-EDP is and my cardiac index. And then we also need to know, is that pulmonary vascular bed reactive? And by reactive, we start these kids, we do a cath, a right heart cath, we do it on oxygen, then we do it on 100% FiO2, then we do it again on some sort of pulmonary vasodilator. We tend to use nitric oxide, you can use others. The issue is that gives us a sense of how much of the pulmonary vascular bed still works. There's data to suggest that by the time you present with systemic right heart pressures, that only 20% of your pulmonary vascular bed still exists. The rest of it is scarred or become permanently hypertrophied. So knowing this is critical. I'm kind of struggling again here. Okay, so there's a definition of vasoreactivity. You drop by more than 10 mean of pressure, or you decrease to a less than 40. But the key is that your cardiac output doesn't fall, or it actually goes up. And you'll see why in subsequent. Yeah, so I'm struggling. Okay, here we go. So back to this guy. He had normal labs, normal chest x-ray. This is the first case, the passing out kid. His 6-minute walk test was terrible. He walked about 2/3 of what he should have been able to walk for his age. And we cathed him. And his original cath data, it's hard to see, but his pulmonary vascular resistance was 11 at baseline, but it dropped to 6 and change after nitric oxide. He had mildly depressed right ventricular diastolic function, but his systolic function was okay. So not bad. So he's borderline reactive with borderline function. And then we got a chest CT. demonstrating what our radiology colleagues felt was kind of findings that were typical for somebody who has idiopathic pulmonary hypertension. We'll disagree with this later, but the bottom line is that it was read as being normal. What we're looking for here is that thing we talked about before, is the pulmonary veno-occlusive disease. It's terrible, terrible, terrible. But it was read as this was not the case here. Could be advance. There we go. So this is the next guy. I just may need you to do this for me every time. The clicker's just no. Yeah, so again, normal labs, normal function. When he did his 6-minute walk test, he desaturated to the 50s. So you know there's either a shunt or his lungs are bad. That does not happen with standard idiopathic pulmonary hypertension. And when you look here, he has, embarrassingly, a large aortopulmonary window. We missed it. We didn't see it on the echocardiogram. He was seen by one of my colleagues as a baby. We missed it then too. So this guy now has Eisenmangers. He's 8 years old. He has a huge AP window, which looks like, you'll see this here, right there. It's not supposed to be there. And he had non-responsive pulmonary vascular resistance with a PVR of 11 with normal function. All right, so we have some work to do. So this is what these two guys have. We've now got our cardiac catheterization, but that's just part of the story, right? So this is, let me just kind of hammer through these to kind of show you the three kind of mechanisms and mindsets that I use when I'm taking care of patients with PH. In the patient that is responsive, meaning their pulmonary vascular resistance responds in the cath lab and drops significantly, I will almost always start them on a single agent, and I'll almost always start them on a PDE5 inhibitor, so the nitric oxide pathway. They're quick, they're very quick to react, they're relatively well tolerated symptom-wise, and you can get sildenafil or tadalafil once-a-day dosing or 3 times a day dosing. For the boys, the priapism can be an issue to be sure, but it's a very well tolerated medicine. It's been around for a modest amount of time now, and it does its job. But what about in the kids who don't respond? Their pulmonary vascular tone doesn't drop with the pulmonary vasodilators. If they have normal function and they're not passing out when I meet them, I'll typically start them on 2 agents. I'll start them on a PDE5 inhibitor plus an endothelin receptor antagonist. Depending on their age, we'll use bosentan, 11% hepatotoxicity risk. It's real, and it's a pain to get labs all the time. Ambrisentan and macitentan can be a little harder to get sometimes, but it's not that bad. So if they're non-responsive and their function's okay, that's my job. That's what I'm starting with. And then last, if you have abnormal function and or are having multiple syncopal episodes at start and you're not responsive, I'm going to typically do a PDE5 inhibitor plus the prostacyclin analog, whether it's epoprostenol, treprostinil, so Flolan, Remodulin, Selexipag, which is an oral version. I'm doing those two because this is clearly the strongest medication class of all. The prostacyclin analog pathway is far and away the most powerful pulmonary vasodilator, but it has the worst side effect profile. It's terrible. Nobody wants to take it. It makes you feel awful, and sometimes people feel like the treatment's worse than the disease. But if we want to stay alive, that's typically the 2 that I'm going to do. I will sometimes start this at the same time, but generally I don't. 3 medications on a 9-year-old is difficult to start from the jump. So back to the first guy. What these different little slides are showing you is that the way that we advance medications is purely based on symptoms and function. It's not their pulmonary vascular resistance. It's not their whatever. Do they have signs of right heart failure on echo? Do they have worsening heart failure classifications? Are their 6-minute walk tests low? Is their BNP climbing? That's what makes me add a medication or increase the dose of the ones that I'm on. And the data bears this out. With worsening classifications, there's all sorts of different risk stratifiers. As they get worse, your mortality rates go up. And this is true with kids as well. We know that in kids who have original diagnosis, their 2-year or 5-year, 6-7-year follow-up after diagnosis is only 60%. It's a terrible disease. So our job now is to try to drop the resistance with the goal of improving the right ventricular function while maintaining good quality of life, and we're trying to achieve a low risk status by optimizing these things. So I put almost everybody on nocturnal oxygen if they'll take it. We all hypoventilate, and having some degree of oxygenation will help with that at nighttime. If you are old enough to take an anticoagulation medicine without bruising or bleeding every 5 minutes because you're learning to walk, I'll start it. Now, the question again of single versus dual medication, I told you my mindset, and here's why. The Ambition trial came out and showed very clearly that in patients with terrible pulmonary hypertension, these are basically a PVRI of around 10 and heart functional class of around 3. The outcomes are clearly improved if you're on 2 medications over one, if you're on a PDE5 inhibitor and an ERA over one or the other. What about 3? If 2 is good, 3's got to be better, right? Well, not really. In the same type of population, starting all 3 of them in the beginning doesn't tend to actually improve their short-term outcomes. So again, this comes back to the idea of I tend to start 2 when they're bad, I don't tend to start 3. So that's what we did for this guy. PDE5 inhibitor, ERA, Q.Nin, nighttime oxygen, and we follow. The other guy, this is the guy with the big AP window, the goals are the same except the first guy, we have every anticipation of thinking that his pulmonary arterial bed or his endothelial cells are diseased. They are going to get worse. That's the problem with idiopathic pulmonary hypertension. We know it is a progressive disease. This guy, though, there's nothing wrong with his pulmonary vascular bed. It was an innocent bystander. And with this AP window hammering his pressure into the lungs for his entire life, they were just doing what they were designed to do. They were trying to tighten down and minimize that extra shunting. And so we have no reason to think that those are going to progress if we can stop the disease process. So if we can safely get him through surgery, that's what we want to do. So what's safe? People would tell you that if their pulmonary vascular resistance after pulmonary vasodilators is less than 4, go for it. If it's greater than 8, don't think about it. If it's 4 to 8, it's risky, but if you can get them to survive through it, you should stop the progression of the disease. The other data that supports this is that in transplant patients who you're going to be putting in a heart that has never seen high pulmonary vascular resistance, but they tend to still do well if you're taking out a piece of garbage heart that's failed, that has developed pulmonary hypertension because of the left heart pressure problems. So we actually did the exact same thing for this guy. He's 8. Putting him on a prostacyclin analog is not going to be great for him in the beginning. So what happens? Well, the second guy, this is the AP window guy, we put him on, and his pulmonary vascular resistance in the beginning was 10. It was still 10 at baseline, but it had dropped to 7 after 6 months of dual therapy. Good, but not good enough. So based on these things, we added selexipag. We added the prostacyclin analog. After 6 more months, his pulmonary vascular resistance had fallen down to 4 after pulmonary vasoreactive testing. We closed his defect. He did great. 6 to 12 months later, we're hoping to start weaning down on the selexipag and see how he does. So the bottom line is he's still going to have pulmonary hypertension forever, but it hopefully won't progress to a point of where he's going to die from that. The other guy, however, this is back to the first fella who was passing out a bunch of times. His labs were better. His end diastolic pressure improved from 12 to 8. His cardiac index remained good. His pulmonary vascular resistance had dropped to 5.5 after vasodilator testing on dual therapy. I thought, I'm the best. I'm doing a great job, right? I'm not the best because he started getting worse. He started progressively getting more tired. He could do less and less activity, and his dyspnea was just bad. It was just getting worse and worse and worse. So we changed him from tadalafil to sildenafil and increased it. And then COVID hit, and people were getting very squirrely, and we wanted to cath him, but we couldn't get him in. And then the family kind of would no-show a few times. And then by the time we got him back in, Dad said, well, actually, if I'm being honest, he did pass out again. So I said, we're doing a cath. We have to look. So we do a cath, and now it's getting worse. His pulmonary vascular resistance is still 8 now. It's climbing. It's getting worse. And so we said, all right, we gotta start this guy with selexipag. We got to do a third agent. We started with the oral before going to a IV or subcutaneous. And as I'm adding this drug, he is actively getting worse. We're not seeing him as much because it's just still peri-COVID. We're not seeing him as much. I finally get him back in the clinic, and his right heart is dying. His septum's flat. It's bowing into his left ventricle. And we get a CT scan because of dyspnea. Now he's declared himself as having pulmonary veno-occlusive disease. He has septal thickening. He's edematous everywhere. This is the CT scan I was looking for in the beginning that he didn't give me. He was negative for his genetics. So we sent him for lung transplant, and he died. He didn't make it. The point being is never trust what you did. Always assume you're wrong. Always assume that you're missing something. You know, hypothyroid in these patients can still make your pulmonary hypertension worse. It can by itself be enough to give you pulmonary hypertension. But your job is, when you take care of somebody with pulmonary hypertension, is to stay in front of it as aggressively as you can. And if a lung transplant is an option, be aware of that and send them early. If it's not, you gotta think of some other surgical things. The problem is lung transplant's not great either. 25% 1-year mortality. And if you survive to a year, it's still another 25% decreasing mortality, survival rate over the next 5 years. So it's a tough diagnosis. And if you have to send them for a heart lung because your right ventricle's failed, it's even worse. So when that's not an option, we do have kind of 2 surgical strategies, and I think this is my last slide. So 2 strategies to decompress the right heart. One is an atrial septostomy. Go in, tear a hole. Decompress that right heart so that you can allow more cardiac output to pop off from the right atrium to the left. We know that they're going to be a little more desaturated, on average 10% desaturation. We know that, you're going to actually increase your cardiac output by about 0.5 liter per meter squared, but it's a high mortality rate, 5% procedural, and then if you don't have anything else that you can do, 38% mortality rate over 4 years. The other, though, the problem with an atrial septostomy is we know that's going to be right to left shunting, and the whole body sees that. From your brain to your toes are going to be desaturated. The concept with the reverse Potts shunt is that it's a left pulmonary artery to descending aorta, and that only makes desaturation go to your lower body. So your head will still be fully saturated, your brain, but your feet will be desaturated, and you can typically tolerate that a little better. The problem with it is it's a big intervention. If you don't have a tiny PDA that I can send to the cath lab to get stented, it's either, there are some risky cath versions where you can just jam a covered stent through from one, or they place, I'm sure they don't jam anything, but they you know, to place that in there, or it's a surgery, which is, you know, these patients are the highest risk surgical candidates, just intrinsic on their pulmonary hypertension. So, you know, the bottom line is that the initial evaluation, if you get nothing else out of this, and if I talk too fast and the translator couldn't catch up, then you may have gotten nothing out of this. But the original evaluation is the single most important thing you do. Spend your time there. Do not start medications because you have a diagnosis. Know what you are treating first. And then advance your therapies based on how the patient is doing. If their functional characteristics are worsening, they need more meds or a higher dose of the one you're giving. But always worry about pulmonary veno-occlusive disease. If your patient is actively worsening with your treatment, you got to assume that's what they have. This guy, I didn't show them, I had 4 CT scans on him looking for this. This is the time he showed up. So, and then just know that there are some bailout strategies when your medicines are not working. So thank you very much for your time.
Thank you.